The topic for tonight's presentation is conscious sedation for the practitioner desiring to be a super GP. So the first question is, what is a super GP and why would you want to be one? So let's address that. So the super GP term is a label that has been around for the last several years, and it resulted from a paradigm shift in the marketplace brought on by differing consumer attitudes. The patients, they want more convenience. And so they're looking for dentists who can provide all of their needs. Who among us has not had the patient say when we tried to refer them out for a particular service, why can't you do that service? And it's a great question, because general practitioners who have traditionally done operative dentistry and cosmetic dentistry and provided some level of specialty care have often referred a lot of treatment out to practitioners who were more qualified, and that makes perfect sense, except to the patient. So for that reason, many GPs have expanded their ability to provide other services, such as surgical services. Most GPs will restore implants, for instance, but many still don't place implants. Many dentists don't do endodontics, or if they do, they don't do molar endo. Many general dentists don't do orthodontics. So the super GP label describes someone who performs all disciplines of dentistry at a high level. They can diagnose, they can treatment plan, and perform comprehensive cases with all of the treatment being done in-house. Now, maybe they don't do that. Maybe they have other dentists on their staff who provide some of those services, but the patient can have all of their comprehensive full mouth treatment performed in one location. Okay, and this requires the super GP to have the latest technological advances, to be properly staffed with not only team members, but associate dentists to support a schedule so that the super GP can do these larger rehab type cases. But in order to do this, you have to have a certain business acumen. You have to be able to present cases and have them accepted so that this becomes a part of your regular schedule. And again, most dentists that I know would like to do big cases. Big cases mean fewer appointments on your schedule book. They mean more production, and they often mean more satisfaction. So the other part of this topic title tonight is conscious sedation. What's that mean? Well, the term conscious sedation is very descriptive. Your patient is conscious, and we don't want unconscious patients that we sedate. So these are patients that are, by the definition of the word conscious, they are able to respond to physical and verbal stimulation. The word sedation simply implies that this person has a certain level of central nervous system depression that makes them less aware of their environment and less anxious of that environment so that they can tolerate treatment better. And we can illustrate the central nervous system depression visually by the spectrum of sedation that you see here. So if we look at this long bar or rectangle, we see at the left side, we see a patient who is completely conscious, and on the right side, we see a patient who's completely unconscious. We want to work on the conscious side of this, and the conscious side of this spectrum is divided up into two parts, as defined by the American Dental Association, whose definitions most state dental boards and Canadian provinces have adopted. And this first definition is minimal sedation. This is at the far left side of this spectrum. And the definition and the key words of this is that this is minimal depressed level of central nervous system depression. And we're using medications to accomplish this. And the patient is able to independently and continuously maintain their own airway. If anything is going to go wrong when we administer a central nervous system depressant, the worst possible thing is that they can't maintain their own airway. So this patient can, and they will respond normally to both tactile and verbal stimulation. And even though cognitively they are less aware, they can still function physically and mentally, and their ventilatory and cardiovascular functions are unaffected. In essence, this patient is more relaxed, but they still respond normally to physical and verbal stimulation. Now, if we were to look at the second part of the conscious sedation, part of the spectrum of consciousness, we are now into moderate sedation. This is a deeper level of central nervous system depression, and the definition of which is that this is also accomplished through medication. And these patients can still respond, but their response is delayed, their response is altered, so it's called purposeful. We have to work to get this response from verbal commands or tactile stimulation. Still, the patient can maintain their own airway and breathe on their own. Okay. Now, if we were to go beyond conscious sedation, where we don't want to go, obviously, we would get into the unconscious side of this spectrum. And now we're into deep sedation or general anesthesia. And these are patients who may not respond at all to physical or verbal stimulation and may not breathe on their own. And this type of sedation is reserved for those practitioners who had advanced training in being able to breathe for their patients. They can intubate and inflate the patient's lungs for them. Now, this spectrum that I've shown you is for the healthy adult patient without any other central nervous system depressants on board. If they are a special population, let's say children, for instance, then this spectrum is condensed, meaning there's a shorter distance between being conscious and being unconscious. In other words, they are much more easily rendered unconscious, okay? Or if they have certain medications in their system. So why would you even be interested in conscious sedation? There are probably people on this webinar tonight who do conscious sedation on a regular basis. You just dialed in to see, what's the latest thing? Is there anything new going on? But there are many of you who are wondering, why am I here? Is it just 1 hour of continuing education? I'm a little bit interested. Well, let me make you a little more interested, because this is what conscious sedation can do for your practice. You can do better dentistry. Now, I'm a dentist. I'm in my 39th year of private practice. And so I can speak from firsthand experience that myself and every other dentist I know wants to be the best dentist they can. And if there's a tool that you can add to your treatment tool belt that will make your dentistry better, then you're for sure interested. And that's what conscious sedation can do. We all know that we try to provide the best dentistry we can every single day we go into our office. But it doesn't always turn out that way. And sometimes it's us, but more times than not, it's not us. It's the patient. The patient has a lot to do with whether or not we get to do that perfect dentistry we all work towards. Okay? And there are certain people that make it really hard to do a high level of quality care. And I'm here to tell you that a sedated patient makes it easier. And let me give you an example. I mentioned earlier how long I've been practicing dentistry, but the very best patient I've ever had and the very best dentistry that I ever did wasn't even within these 38 plus years of private practice. It was in dental school, okay? And it wasn't even a real person, it was a mannequin. Remember the mannequin that we all got to practice on. And we weren't good at first, but after repeated attempts, our work got better. But the mannequin made it easier for that to happen because at least my mannequin, the access was easy. There wasn't any tongue. There wasn't any saliva. The patient didn't want to talk to me. There wasn't a central nervous system connected to the teeth. And if I didn't like my work, I could just take the tooth out and put another one in and reboot. And, we can't do that with live human beings, but I'm here to tell you that properly sedated patient is the closest thing to that mannequin in dental school that you're ever going to have. And not only can you do better dentistry, you can do a lot more dentistry. These patients tend to need a lot of dentistry. They tend to have had professional neglect for years, sometimes more than a decade. They need a lot of dentistry and they want a lot of dentistry. There's just this obstacle of anxiety that has to be overcome. Once we overcome that, they want their mouth fixed. And so they also want it done all in one appointment. So that's what we can do for them. In my office, for instance, every day I walk into my office, there's one patient scheduled in the morning. I might have a second patient that I do a few little things on, but from 7 a.m. till noon, I've got one patient. We sedate them and we do full mouth dentistry. And it's so much better than having 20 patients on my schedule. So there's less stress for me, for my team, and for sure from the patient. And there's a lot more gratitude. I mean, patients don't fully appreciate the love and the time and effort and training and expense, what we invest to do dentistry. But if that patient gets the kind of smile that they thought they would never have, and they get it completely comfortable, which they thought would never happen, then there is a lot more gratitude from the patient. And that's good. And these patients always show up. Why do they show up? Well, because they want what you're going to do for them. But also a very practical reason is that these patients pay for these appointments in advance. They don't even get scheduled in my office until they pay for the appointment in full. So something magical happens when people pay in advance. And people accept these large cases at a higher rate of case acceptance. Now, that may seem counterintuitive to you because this patient's got every reason not to show up, not to accept dentistry, but the opposite happens. Why? Because we're giving them something that they really want. And people will write big checks for things they want. They won't write big checks for things they need and don't want. So who can we help? Who are these patients? Well, I've already alluded to the highly anxious phobic patient, and this makes up the overwhelming majority of the patients that I sedate. But I offer it to all my patients because it doesn't just help the anxious patient. It helps the patient who is a severe gagger. And we've all got these people that are really hard to treat. And gosh, it's psychological. These people aren't, skin and bones. Something's going through their mouth. Okay. But the thought of you working in their mouth is more than they can tolerate. They just start gagging. We can overcome that with sedation. The patient that's difficult to numb. I mean, we get profound anesthesia on the overwhelming majority of our patients, but occasionally we run into that patient. It's a challenge to get profoundly numb. If we sedate them, they'll get numb. And there are psychological as well as physiologic reasons to explain that. And then there's people who just, they need a lot of dentistry and they won't accept your treatment plan because it's going to require multiple visits. What if you could get all their dentistry done in 2 or 3 visits if they're sedated and comfortable? And we've got the complex restorative patient. We've got the all on X patient. We've got the patient that we're going to be maybe prepping an entire arch, maybe 2 arches. That's a long time for both you and the patient to be working. If they're sedated, it seems like it's only a few minutes. And then you've got the patient who's just really sensitive. Okay. And if you sedate them, then they'll have less discomfort, both during as well as post-operatively. Okay, so that's who we can help. So now let's look at the different types of conscious sedation that you could do. And we can look at this, and we've already looked at it from the point of depth of central nervous system depression. Now let's look at it from the way we administer the medication. It can be either administered intrally or parenterally. Intrally refers to the enteric membranes, which line the GI tract, all the way from the oral cavity to the end of the alimentary canal. And this is usually swallowed medications, but it can be medication that is placed underneath the tongue, sublingual medication. It can also mean rectal, but we don't do that in dental offices. Now, there's also the parenteral method of administering sedation medication. So this is outside the GI system. So this is intravenous, this is inhalation like nitrous oxide, this is submucosal, this is intramuscular, and more exotic forms like intranasal, intraocular, transdermal, transmucosal, and intrathecal through the spinal column. So let's just look at the two main ways that dentists use conscious sedation. The first is the enteral or the oral sedation pathway. And the advantage to this is that it's easy. Nothing is more simple than giving a patient a pill. Okay? And patients accept this, especially the patient who is anxious. They would much rather take a pill than have a needle in their arm. Doesn't cost much, and the training is usually very straightforward and doesn't take a lot of time, and it's implemented very easily. There's less likely to be an adverse reaction with medication that is swallowed, and the reason is something called the first pass effect, so that our body, specifically our liver, has a chance to reduce the potency of that medication before it enters the general circulation. And if you're going to have an adverse reaction with oral sedation, it's less likely to be severe. There's lots of good reasons to do oral sedation, but like anything else, nothing's perfect. So what are the disadvantages? Well, it does require more patient cooperation. They are going to take medication outside the office. They are going to take medication inside the office, and they have to swallow that medication. They have to get it in time for it to be effective. This is usually not a problem, but let's list the disadvantages. With oral sedation, it takes longer for it to work because it's got to get through the GI system. It's got to pass through the first pass effect before it can get to the general circulation and into the brain where it has its site of action. So it often takes an hour after the patient arrives at your office before they are sedated enough to begin treatment. And because the medication is going through their GI system, it can be affected by other things in the GI system, for instance, food. So if we don't have our patient in PO for 6 to 8 hours prior to that sedation appointment, oral sedation's absorption is going to be erratic and inconsistent and incomplete. And arguably the biggest disadvantage to oral sedation is that you can't titrate it. Now, the definition of titrate means you administer a very small amount of medication, and within a very short period of time, just a few minutes, you know the full effect of that dose of medication. And we can't do that with oral medication because it takes longer to work. So as a result, it is easier to either under-sedate or over-sedate your patient with oral sedation simply because we can't titrate it. And it's going to last longer. If it takes longer for the medication to get into the system, it will also take longer for that medication to get out of the system. And this means that your patient will go home still somewhat sedated. And with oral sedation, because you don't have an IV into the general circulation, we have less ability to readily lighten or deepen the sedation. Sometimes we want to lighten the sedation so that we get more patient cooperation to check the occlusion or to take an X-ray or for the patient to get up and go to the bathroom. And sometimes we want the sedation to go deeper kind of quickly so that we can do a more invasive procedure while they're sedated. Now, there's some things that we can do with oral sedation. We've got some tricks, and this course was not meant to be comprehensive. It's meant to give some of you a taste of oral sedation. But I want you to know that despite these disadvantages, oral sedation is a very effective way and a very safe way to sedate your patients. But let's go ahead and look at the parenteral method. We'll talk about intravenous conscious sedation. And I teach an IV course in my learning center in Kentucky every month, okay? And this is what I do in my practice. These are the advantages to IV conscious sedation. Number one is we can titrate, okay? We've already covered this topic of titration. And what it will allow us to do is to better dial in the level of CNS depression that we intend, either minimal or moderate sedation. And it has a short onset of action. Depending on the patient, depending on the medication that we use to sedate the patient through that IV, the patient could be sedated within 5 minutes and be ready to go. So compare that to the hour that it took us with oral sedation. And because the medication is getting in faster, it's also getting out faster. So they have a shorter recovery time. And not only can we sedate the patient, but if we have an IV in, we can also administer analgesics like an opioid. Okay, now this is not what we use to sedate the patient with, but there are times when we want pain relief in addition to sedation. And we can do this with IV. And if we have that patient who is the hyporesponder, the patient that is tough to sedate, then they're better suited for IV sedation. There's less likelihood that we're going to have low blood sugar from being NPO for 6, 8, 10, 12 hours with an IV in place if we use IV fluids that have dextrose in them. And there's less likely they'll be dehydrated. And then finally, we have an open line in for the administration of emergency drugs should that unlikely event occur. So what's the disadvantages to doing IV sedation? Well, it involves more training, okay? Usually at least 60 hours of didactic training, clinical experience that involves at least 20 live patient experiences. And so there's extra time and there's extra expense involved in adding IV sedation to your practice. And IV sedation, because of its short duration of action, remember, it gets in quick, it gets out quick. This can be inconvenient. For instance, if we're using a sedative drug like Versed, it lasts about 20 minutes. So you have to continue to administer more medication throughout the appointment if it lasts several hours like mine do. And that can be inconvenient to you and your team. And then there's the issue of needle phobia. Okay, many of these patients are anxious partly because of needle phobia. So we've got to overcome that. And then I found as a teacher and trainer of IV sedation that there's some needle phobia on the part of dentists who give more injections than any other professional in the healthcare profession. Okay, but yet when we go outside the mouth and we go through skin and blood vessels, then it's a different game. So how do we overcome these disadvantages, including IV sedation, because we are using more potent medication, there's a potential for more complications. So the answer is this. The answer is to combine the two. Okay, now if you did, you're still going to need training in both oral and IV. But what we teach at my training center is a combination method, oral and IV. And by doing this, we realize all of the advantages of both and minimize the disadvantages of both. We're going to prolong the duration of the IV sedative medication and reduce the frequency and the amount of that IV agent. Therefore, we will reduce the potential for complications. And because our patient from the oral sedation at the beginning of the appointment is already relaxed, when we go to insert the IV, the patient is more relaxed and comfortable. The dentist is more relaxed and comfortable, and the veins are bigger and easier to hit. So let's look, again, this is not meant, to teach anyone who is new to this topic to go out and sedate tomorrow morning. However, I do want to cover the basics of the process so that you get an idea of what's involved. So I'll be looking at all 7 of these topics in a little bit more detail. Okay, so we start with patient selection. And just like with anything you do in your practice, we want to make sure that what we are going to do for the patient and what the patient expects are on the same page. So again, the patient's expectations need to be that they will be more relaxed, but they will still be conscious. Okay. The next thing we look at is their medical history. And there are certain medical conditions that are yellow flags. And for instance, advanced age. Okay. And in anesthesia, once a patient gets to the age of 65 or older, then they are considered elderly and they are more sensitive to medications. So we have to dose lower and we have to dose slower. And then we've got the patient who is obese, and because of their increased fat percentage in their body, then they soak up this medication that is fat loving. So the medication gets in the general circulation, it's on its way to the brain, and it ends up getting stored in fat stores. And so it takes larger doses. And the obese patient tends to have more neck girth, and therefore they have more airway complications when they're sedated. We've got smokers who are challenged to sedate because nicotine is a stimulant. And what we're using are depressants, and they counteract one another. And also, nicotine is a liver enzyme inducer, so it tends to burn sedation medication up faster. So smokers are going to be hypo-responders, and they tend to also have this craving that prevents them from being sedated for longer periods of time. And then there are patients with compromised airways. And these could be patients who have obstructive sleep apnea. For instance, they could be people who have that Mallampati class 3 or 4, where they have a lot of soft tissue around their upper airway. It could be some type of congenital condition that gives them a compromised airway. We can sedate these people. These are not deal breakers, but they do make sedation a higher risk. Now, there are red flag conditions, and these are deal breakers. And these are patients who have not had a medical evaluation with blood work within the last 2 years. And if they are over the age of 50, it needs to be within the last year. And if they are over the age of 60, it needs to be within the last 6 months. So this would be a person who is not appropriate for sedation because we don't know who we're sedating. And then any patient who has an uncontrolled medical condition is not a candidate. Anybody who has an ASA4 status, meaning they have a severe medical condition that is a constant threat to their life, they're not a candidate. Anyone who has severe respiratory disease like COPD is not a candidate. And anybody who has severe liver disease or who is pregnant or who might be pregnant is not a candidate either. The next thing is that we need, once we've chosen this patient, is we need to work them up and get them scheduled. So we're going to have a separate appointment prior to them being sedated in which we get their baseline vital statistics. We're going to get their heart rate, their blood pressure, their oxygen saturation. We're going to do an EKG from our monitor, and we're going to get their baseline O2 saturation or CO2 end-tidal CO2. We're going to give them their pre and post sedation instructions. And we're going to get consent for everything that we'll be doing, including the sedation, while they are in our sedation appointment. We're going to get the contact information of the responsible companions, both bring and take them home. We're going to make financial arrangements. And if they have paid for their next appointment in full, we will dispense medication. Now, when we schedule these patients, they are best sedated in the morning. Okay, they're not as tired, they're not as anxious. It's a whole lot easier to be NPO while you are asleep. We're going to schedule an hour to get them sedated if we're doing oral sedation, and we'll schedule about 20 minutes if we're doing IV sedation. And the treatment time can be up to 4 or 5 hours, okay, as long as the patient's vital statistics are within normal limits and they subscribe to the definition of being consciously sedated. Now, we'll use some pre-appointment dosing with oral medications. Excuse me. So the night before, we'll use a long-acting benzodiazepine, and this will shorten the time it takes for them to get sedated on the day of the appointment, and will mean that we don't have to administer as much medication to reach that minimal or moderate level of sedation. On the day of the appointment, or prior to the sedation appointment, then we may, depending on our state regulations, be able to sedate them prior to their arrival at the office with a dose of oral medication, like a short-acting benzodiazepine. So once they arrive at the office, we're going to determine what dose of sedation medication they need based on their appearance and their response to questions. Again, if they respond normally, they're either not sedated or they're in minimal sedation. If they respond purposefully, meaning we have to work to get them to respond, then they are in moderate sedation. So we'll be using appropriate doses of an oral sedative within the benzodiazepine class, whether we're doing oral or IV sedation. And we'll be doing this at appropriate intervals to achieve the desired level of sedation. And again, once you come to a training course, we'll make all of this very clear. We'll cookbook it for you. And if we are doing IV sedation, we can use analgesics like an opioid at appropriate intervals and appropriate dose sizes in order to achieve the analgesia that we are looking for. We will need to monitor these sedation patients. The most important thing we monitor is consciousness, and we check in with our patient periodically to confirm they can respond physically and verbally. We'll also be measuring their heart rate, their blood pressure, their oxygen saturation percentage, their end-tidal carbon dioxide, and we'll also have an EKG. And all of this will be measured, except for the consciousness, will be measured by an instrument, okay, a pulse oximeter that has additional capabilities. And we'll redose the patient during the course of the sedation appointment in order to keep them at the proper level of comfort, and so that we can perform what is typically a long appointment and our patient is comfortable for the entire period of time. Now, keep in mind, at all times, this patient must be conscious. And the protocols we use, the medications that we recommend, and the dose sizes and how we dose the patient will all make that happen. Okay. And again, we're going to be using the same parameters in order to determine if the patient needs more medication or not, their appearance and their response to questions. And we'll make sure that we are dosing at appropriate intervals to make sure that our patient is comfortable but not over sedated. And then we dismiss the patient. Okay, at the end of the appointment, our dentistry is done, and they have to have a responsible companion to take them home and stay with them until they're completely recovered. Excuse me. But before we can release them, they must demonstrate that they are mentally oriented ×3. What's that mean? We ask 3 questions. Where are you? What day is it? And what is your name? If they can answer those 3 questions, they are considered mentally oriented ×3. And they must be physically coordinated to leave with minimal assistance by way of their responsible companion. And they must have stable vitals, and we give them post-sedation instructions. Okay, so that's the process. Okay. Again, I went through that very quickly. I wanted to cover a lot of ground tonight. And for those of you who I'm sure have a lot of questions, those questions will be addressed in a more comprehensive course. So what is that course? Okay, well, your state or province determines what that course is. Okay, and every state has their own regulations. Many of them have adopted the recommendations of the American Dental Association. So in order for minimal sedation, there aren't any training requirements in most states. There are for moderate sedation. But in the past, the regulations were focused on how the sedation was administered, either intral or parenteral. And now it's all about the depth of sedation. So they don't treat oral and IV sedation all that differently. What they do is they separate out, are you going to be providing minimal sedation or are you going to be providing moderate sedation? If you are providing moderate sedation, okay, then you are administering more than the MRD or the maximum recommended dose of that sedation medication. And your patient is in a deeper level of central nervous system depression, and they require you to take a 60-hour course continuously and do 20 live patient experiences. And this is the course that I have referred to that I provide in my teaching center every month that is sponsored by Docs Education. And, but there are several courses and, again, find out what your state or province requires. And if you see the value, like I did many years ago, in providing conscious sedation to your patients, then the investment in time or money will come back to you many, many, many times. I don't have time to tell the story, my own story, but the short version of it is that providing sedation in my practice allowed me to change the course of my practice, work less, be rewarded more, and semi-retire at a very young age. You will have to have a pulse oximeter, and you will be trained at the course in how to use that. And the requirements also require you to be ACLS trained, and that is something that we provide in our training as well. So that's the next step. You can go to docseducation.com and you can learn more about oral sedation or IV sedation or what your state or province requires. And you can look at the curriculum that we provide. Docs Education is an organization that I co-founded in 1999. And I'm very proud of what we've been able to accomplish. And, just about every aspect of sedation is covered in our curriculum. So I am also very happy that I timed this just about right. I wanted to finish this in about 45 minutes so that we had time for questions. And, I'll take those questions now, but I want you also to know that you can reach me with emailed questions at tony@tonyfeck.com. And you can also reach Tin, that you met at the beginning of the webinar, and she can answer any questions you may have about your continuing education or of the many fine services provided through MicroDental Laboratories. So Tin, I'm going to turn it back to you, and we can handle some questions if we have any.
All right, Dr. Feck, we have another person from our team, Maxwell. He will handle all the Q&A questions at the moment.
Okay. think Maxwell is muted.
Max, are you
Can
muted?
you hear me better?
Yes, we can hear you now.
Okay, sorry about that. First question for you, Dr. Feck. How is the reversal agent for this sedation administered?
Okay, well, it's a great question. Obviously, somebody knows more about this process. I didn't even talk about the reversal agent, but let me address that right now. With the sedative medications we use, they're in the benzodiazepine class. And the benzodiazepines have a reversal agent in case the patient is oversedated or in respiratory depression. So you can reverse their central nervous system depression by using a medication called flumazenil. And that's the generic of the trade name romazicon. And this can be administered if you're doing oral sedation by a sublingual injection of 2 to 3 cc's of flumazenil, or if you're doing IV sedation, you can administer 2 cc's of the sedative in their IV line.
It looks like we have another question following up. Dr. Feck, what do you charge for sedation?
Okay.
If you don't mind us asking.
Not at all. And keep in mind, what someone charges is unique to their circumstances. There shouldn't be one set charge for any dental procedure, but we charge $400 for the sedation, regardless of the length of the sedation. That $400 charge covers the time that it takes to get them sedated. And after that, we charge our regular fees for the dentistry we do. And that works out really well because we tend to do a lot of dental procedures in these sedation appointments. And we tend to work more efficiently. So we don't need to charge any more than that. And that's never been an obstacle to a patient who really wants the dentistry done and realizes that sedation is the best way to get that accomplished. Now, again, you're going to charge something unique to you, and you're going to base that charge based on things like, how many operatories you have. Okay, I have 13 operatory office, so my operatories are valuable, but they're not as valuable as a dentist who only has 4 operatories. Okay, because you're tying up an operatory to sedate that patient. Your overhead is going to affect this. Just like it affects the cost of any dental service. But $400 is the answer to that question.
Dr. Feck, we do have another question. How is nitrous oxide used to help with the sedation process?
Excellent question. So I didn't talk about nitrous oxide, but many of you are familiar with nitrous oxide. You use it in your practice. We will use it during sedation, during the induction of sedation. In other words, when our patient is first getting sedated, when we administer the local anesthetic, we will use 30% nitrous oxide for short intervals of time. We never use more than 30% in a sedated patient because nitrous oxide plus your sedative agent are going to have a synergistic central nervous system depressant effect. Okay, so you may think 30% doesn't do much, but in a sedated patient, it's like using 70% nitrous oxide. So we'll use it during the delivery of local anesthesia. We'll use it during the venipuncture, inserting the IV, and we'll use it during invasive parts of the appointment.
Another question coming in, Dr. Feck. Do you use or do you adjust the sedation protocol for patients who perhaps smoke or use any sort of medicinal drugs like marijuana?
Okay. The answer is yes. So let's look at smoking. I mentioned during the short presentation that smoking presents some challenges to sedating a patient. One is that the nicotine is a stimulant, and so that makes it a little bit more challenging to sedate our patient. So we're typically going to need larger doses on smokers. Nicotine is also a liver enzyme inducer, meaning the liver enzymes which break down our drugs work at a greater rate. So the bottom line is that smokers need larger doses. Smokers also should have shorter appointments because they're used to having that nicotine, that drug that they are addicted to on a regular basis. So if our appointment exceeds that normal interval, then these patients will typically have a craving, which brings them out of their sedation. Now, the marijuana user, I treat marijuana just like I treat alcohol. So if a patient uses marijuana on a regular basis, then what would I do if they drink beer every day, okay, or liquor every day? I'd be okay with them using their marijuana the day before the sedation appointment, but not on the morning of, okay, not prior to the sedation appointment. And then I wouldn't want them using their marijuana on the day of the sedation appointment after they are dismissed until they are completely recovered.
Okay, Dr. Feck, another question coming in anonymously. Is Ativan a good sedation drug for use in dentistry?
I'm sorry, I didn't get the drug name. Is what?
Sorry, is the drug Ativan, Ativan?
Okay, Ativan. Okay, all right. So Ativan is a benzodiazepine. So it is in the family of medications that we use in our sedation protocols. It's not the most desirable one. For the nighttime dose, night before dose, then a long-acting drug like Valium, which is diazepam, is the best drug we can use the night before. On the day of the appointment, the best medication for oral sedation is triazolam. And if we're using IV sedation, the best drug is midazolam, which is Versed. Both triazolam for oral sedation and Versed for IV sedation are better than Ativan because they're more potent, so we don't need as big a dose. They're shorter acting, okay? They work faster, and they don't last as long. And they have a better track record. So there are instances when you come to our course, you'll learn when Ativan would be a candidate for sedation medication, but its use is limited.
Okay, another question coming in from Dr. Vu. What would you do if a patient asks for you to write them a prescription to Xanax like other dentists usually do, rather than working up the sedation process like you suggest?
Okay. I wouldn't do that. If I prescribe a drug like Xanax, then I am, in essence, sedating the patient. And if I am sedating the patient, then I have to accept all of the consequences that come with sedating the patient. If that patient were to take Xanax and drive themselves to the office and have an accident, then I bear some liability. If that patient were to show up at the office and they take their Xanax, and Xanax is a very safe drug, people take it all day long, okay, and do fine. But what happens if the patient were to mix that with, the marijuana, or they were to mix that with, alcohol or some other central nervous system depressant? Then do I bear some responsibility? I do. So since the advent of conscious sedation in dentistry, we've raised the bar for dentists. And so the day of you just writing a prescription for some Valium or some Xanax, and you don't have to have a monitor, and you don't have to have consent, and you don't have to have a responsible companion, those days are over. Doesn't mean dentists don't do it, but those dentists are playing with fire. And if you're going to sedate your patients, even minimal sedation, get training and make sure you reduce your liability and you protect your patient as much as you can.
Great answer, Dr. Feck. A few more questions that I see that we have listed here. Let's start with this one. What kind of monitoring is required for minimal sedation? Is there anything that changes with the process?
Okay. So there are many monitors that are on the market, and many of them are really good monitors. I'm partial to the one we use. It's made by a company called Eden, EDEN. You want a monitor that does all of the vital statistics that you need to measure. Okay, heart rate, blood pressure, oxygen saturation, EKG, end-tidal CO2. End-tidal CO2 is something that was recommended by the American Dental Association, and state boards are just jumping on board. So, we're just, recommending that as well. So if you've got a monitor that measures all those things, and you want a monitor that is high quality, meaning that you can trust its accuracy and it's reliable. And, we put our monitors through a lot of rigor, and, sometimes, we'll hit them. Sometimes they'll even fall off the countertop, and you want something that can take a beating and will continue to give you reliable numbers. So when you invest in a monitor, just like any investment in your practice, technology-wise, it often pays to get something that is better quality.
Okay, we have time for a couple more questions. Let's move down to another anonymous question. Dr. Feck, what type of emergency situations are you likely to encounter during sedation?
Okay. Well, and I understand whoever asked that question, because dentists tend to be, ultra conservative and worry. And I'm right there with you about what can go wrong. And the good news is, with the protocols that we teach, the likelihood of an adverse reaction are extremely small. And in docs education, we've trained over 100,000 dentists and team members in the 22 years of our existence. And by our closest estimate, it's resulted in over 2 million sedation appointments. And there's not a single one of those that has resulted in the very worst outcome, okay, a patient not surviving, or even a trip to the hospital. Now, has that happened in dentistry? It has, but not with our protocols. So that means that we are extra careful in selecting our patients, okay? Number two is that we use protocols that err on the conservative side, so that our patient is less likely to be over-sedated. And we monitor our patient's vital statistics so that if there is even this hint of a problem occurring, we are alerted at the earliest possible opportunity. Quite frankly, the worst adverse event that I've encountered in all the years that I've been sedating patients is nausea and vomiting. And you think, well, that's not bad. Well, it's unpleasant for everybody, But in a sedated patient, we want to make sure that we prevent nausea and vomiting, and should it occur, that we address it very quickly.
Thank you for your insight. Final question that we have time for. Do you sedate patients to insert cosmetic dentistry? And if so, how do they approve the final appearance?
Okay, great question. Okay. Many of the patients who I sedate, they're not going to have dentistry done any other way, including putting in a crown or a bridge or an implant supported restoration. Even if local anesthesia isn't necessary, they want to be sedated. So how do they give cosmetic approval for this? Well, they designate prior to that appointment someone who will approve the cosmetics on their behalf. Okay, and I don't want that to be me. I want someone else to do that. If we can get that in writing, then we as the provider of that cosmetic treatment, we have really high standards, then the likelihood that there'll ever be an issue with their cosmetic satisfaction is very, 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 very low.